Hello, everyone. Welcome. Welcome to today's webinar. We're just waiting for all of today's participants to come in from the Zoom waiting room, and we'll get started in just a moment. Fantastic to see those numbers going up. Welcome, and thank you for being here today. As people are coming into the webinar room, let me welcome you again to today's webinar, From Data to Action, Shaping People-Centered Health Systems, where we'll be talking about learnings from the People's Voice Survey on health system performance. Fantastic to see so many of you joining from around the world. Please go ahead in the chat box and share your name and where you're joining from. Great to know who's participating in today's session. The chat is available also for any technical assistance that you need with today's webinar or any questions. I think in the interest of time, we will go ahead and get started, but it's fantastic to see people still coming into the room. Jenna, can you take down the slide, please? Great. So let's kick it off. As I mentioned, thank you again all for joining us for From Data to Action, Shaping People-Centered Health Systems, Learning from the People's Voice Survey on Health System Performance. It's fantastic to see so many of you joining from around the world. My name is Amy Baldasser-Bush, and I have the distinct pleasure of serving as your moderator for today's session. I'm a Senior Director and Practice Area Lead for Health Policy, Advocacy and Engagement and Integrated Healthcare at Management Sciences for Health, or MSH for short. And I also oversee our work on social participation and advocacy for universal health coverage and person-centered primary healthcare. So I am particularly excited about today's event as we learn about this important new research and discuss opportunities for bringing a social voice to health systems measurement. We have a fantastic panel today, and we look forward to the engagement of all of you in today's discussion. Before we begin, a few reminders about today's webinar. Jenna, could you please share the logistics slide? The webinar is being recorded, and we're pleased to offer simultaneous interpretation in English, French, and Spanish. The participants can all select your preferred language by clicking on the globe icon, see the image on the screen, at the bottom of your screen. When you do so, you'll see the option to choose the English or French or Spanish channels, and you can also mute the original audio if it's distracting you from hearing your language of choice. Everyone does need to select a language to ensure you'll be able to listen to all of our speakers. Please note that one of the presentations today will be in Spanish. If you need technical support, please connect with my colleagues in the chat box. My colleagues are standing by to collect your questions and comments throughout the event today, so please feel free to enter them in the chat box at any time, and we'll do our best to respond to as many as possible. We welcome your questions in English, Spanish, or French. A quick overview of the event and our agenda for today. Published in December 2023, just in time for the International Universal Health Coverage Day, the Lancet Global Health Series on the People's Voice Survey on Health System Performance explores health system accountability through examining quality and confidence in health systems. The series contributes key new findings on the importance of amplifying the voices of communities to inform actions for more effective and person-centered health systems globally. If you haven't had a chance to read the 6 papers in the series, I highly recommend you read them. My colleagues will share the links in the chat box so you can access them during or after the event. The timing of the release of this research and today's discussion are particularly relevant as governments around the world are committing to more people-centered health systems. At the United Nations High-Level Meeting on Universal Health Coverage last September, World leaders renewed their commitment to accelerating progress towards achieving universal health coverage and the Sustainable Development Goals by 2030. In the political declaration from that meeting, world leaders specifically committed to advancing social participation. The text says that the governments of the world commit to involving all relevant stakeholders, including local communities, health workers, civil society organizations, and youth, to systematically inform decisions that affect public health so that policies, programs, and plans better respond to individual and community health needs while fostering trust in health systems. At the World Health Assembly this year, the decision-making body of the World Health Organization, member states are also pursuing a resolution with new commitments to social participation, empowering people and communities to participate in and influence decision-making processes for health. Certainly, our pandemic experience has shown that strong, effective health systems are the ones that are trusted by their end users and are responsive to the needs of the populations they serve. In fact, WHO Director General Tedros calls trust the most valuable commodity in health. But as the People's Voice survey points out, data on measures like trust in health systems are not regularly collected. The People's Voice survey was designed to address these gaps, and we're very fortunate today to have an opportunity to learn more about the survey findings from Dr. Todd Lewis, the People's Voice survey workstream lead for the Quest Network. Our event today will kick off with opening remarks from Marion Wentworth, President and CEO of Management Sciences for Health. We'll then have an overview of the People's Voice survey series from Dr. Lewis. Following his presentation, we'll be joined by some leading civil society advocates and researchers from Argentina and Kenya, which are two of the focus countries for the survey, to share their perspectives on the research. We'll have some time for dialogue with the panelists, and then we'll open it up and have plenty of time for questions and discussion with all of you. We'll wrap up with closing remarks from Dr. Dan Schwartz, the Vice President of Global Health Systems Innovation at MSH. So let's get the event started. Please join me in welcoming MSH's President and CEO, Marion Wentworth, to the virtual floor. Marion, over to you.
Great. Thank you, Amy. And thank you all the participants for taking time to discuss a topic that is, central really to my heart and my career. And thank you, Todd Lewis from the Quest Network at the Harvard T.H. Chan School of Public Health for helping coordinate today's events. Rosemary and Carmen, I'm looking forward to your remarks as well. Esteemed colleagues, imagine a mother with a sick child walking miles farther than she needs to in order to reach a private hospital, spending more money than she can afford when a closer public facility could have helped her son sooner, costing her less. Why would she do this? Well, has anyone actually asked her? That's what the People's Voice survey is about, asking those important questions. Today's conversation is about what we're going to do with the answers. Many of you are familiar with MSH and our 53-year history strengthening health systems. Our approach is rooted in the Tao of leadership, which is about going to the people, learning from them, and starting with what they have. This approach has not only inspired us over many, many years, it has formed the basis of our current organizational strategy. This strategy commits us to a few actions that are pertinent for today's discussion. It calls for us to focus on supporting local leaders to develop resilient, person-centered health systems that are designed around individuals and communities' needs. It calls for us to further localize our efforts by partnering with communities and civil society to help shape the health systems that serve them through social participation processes and advocacy efforts. And lastly, our strategy commits us to demonstrate our approaches and impact with data, ensuring that MSH is contributing to the global evidence base and directly supporting local organizations to contribute their own voices and evidence to our global work. For all these reasons, it's critical that we stay at the cutting edge of evidence and innovation in strengthening health systems. And you know why it matters. We all know the failures that happen in this regard. They look like that mother I just spoke about a few minutes ago. They look like the profound distrust and lack of confidence in a local health system that is rife throughout our world. And they look like the deadly consequences of that mistrust when a health system isn't meeting people's needs. In many of the communities where MSH works, our partners in the Ministry of Health aspire to provide high-quality public sector services, only to see people bypass those facilities and go to the private sector, paying huge sums of money, often catastrophic sums, for care that sometimes is not only not high quality, but potentially detrimental to their health. Why would someone like that mother do that? Maybe because they don't trust the alternative. A strong person-centered health system is one that first and foremost evokes and builds itself upon a foundation of trust. Without trust, it does not matter if you have access, because no one will use those services. High quality utilization is dependent on trust. So yes, our new strategic plan is committed to strengthening health quality, person-centered, equitable health systems. And at the core of that building is that people are designed, that people they are designed to serve can trust and respect it. In this regard, the People's Voice survey published in the Lancet in late 2023 is a great example of the type of innovation evidence we need to build better person-centered systems. It's just a starting point, but the survey's large body of data can help policymakers and organizations such as ours learn more, better inform our program development, and importantly, continue to engage in further conversations and more research with the communities we serve. I hope today's conversation is just the beginning, because people are talking and it's really on us to decide, are we listening? We're excited to convene this discussion about the new work, engaging in the data and hearing directly from the communities we serve and thinking critically about how best to apply its lessons. I am pleased to welcome all three speakers for this session, who will be introduced more formally by your own Amy Baldasser-Bosch. Over to you, Amy.
Thanks, Marian. I'm excited to get started in this conversation as well, and to discuss how the findings can be used to help improve health services in countries around the world. So I'm very pleased now to introduce our distinguished panelists for today's event. Please join me in welcoming them as they come to the virtual webinar floor. Our first panelist for today will be Dr. Todd Lewis, who is a research associate at the Harvard T.H. Chan School of Public Health, and as I mentioned before, the People's Voice Survey workstream lead for the Quest Network. Todd recently completed his PhD, congratulations, in population health sciences with a specialization in health systems at the Harvard T.H. Chan School of Public Health. His dissertation work focused on user and facility level determinants of high quality primary care across multiple low and middle income countries. Previously, he was a senior analyst at the Advisory Board Company, where he conducted mixed methods research examining hospital best practices with a focus on physician issues and clinical programs. Next up is Carmen. Yes, if you can share the speaker slides, if my colleagues can pop up the speaker slides, that would be great. Our next presenter will be Carmen Ryan. She's the Public Advocacy Coordinator and Public Policy Implementation Supporter at Fundación Huésped, an Argentine organization with a regional scope that conducts scientific research and actions for disease prevention and promotion of rights to ensure access to health. A lawyer by training, over the last 15 years, Carmen has worked with civil society organizations, international organizations, and public officials on different human rights projects. Carmen is a member of the core committee, along with Management Sciences for Health, of an initiative called Social Participation for Health, Engagement, Research, and Empowerment, or SPHERE for short, which is an initiative that brings together civil society representatives, multilateral agencies, implementers, and academics in the service of health reform with a focus on universal health coverage. And our next speaker will be Rosemary Mburu. Rosemary is the Executive Director of Wacky Health, an African regional advocacy organization. She's based in Nairobi, Kenya. Rosemary is a global health advocate and civil society leader working to create political will for improved health outcomes in Africa. Rosemary oversees the Civil Society Platform on Health in Africa, the Global Fund Advocates Network, the Africa Hub, and the Africa Free of New HIV Infections Network. She's also a member of the Vaccine Advocacy Resource Group, and I have the distinct pleasure of partnering with her on the Wacky Health MSH co-hosted Secretariat for the Civil Society Engagement Mechanism for UHC 2030. Thank you all again for being here today. We look forward to the discussion. I'm pleased to hand over now to Todd for his on the Lancet series and the really interesting data from the People's Voice survey. Todd, over to you.
Thank you so much, Amy. Good morning, good afternoon, good evening to all of you. I've been monitoring the chat and I'm so thrilled to see such widespread attendance from around the world. It's really amazing. And thank you so much. A huge thank you to Amy and the team at MSH for convening this event and for inviting me to participate. I'm really thrilled to be here to speak about the People's Voice Survey. As Amy mentioned, I lead our work on the People's Voice Survey at the Quest Network. And just in brief, the Quest Network is a consortium of health system researchers from around the world working jointly on health system research projects. So today, I speak to some of my own work, but I also am a representative of a wide network of co-authors and researchers who contributed to not only the papers in the series, but also the implementation of the People's Voice Survey. So I'm going to first give you a rather rapid fire overview of what the People's Voice Survey is. And I'm going to then give you just a tasting menu, really, of some insights from the first round of analyses. Great, next slide, please. So before we get to the survey itself, I want to get everyone thinking about how we currently measure health system performance. So often, think about this in your own country. This is things like workforce, so maybe doctors per capita, infrastructure, so things like what types of health facilities do we have in the country? How are they distributed? Are they primary care clinics or hospitals? Health spending, health and risks, utilization and efficiency, so for example, a length of stay measure. Now, these are all critical things to measure for the administration and management of a functional, efficient, operational health system. But what you might notice about all of these things is that they all come from the supply side of the health system. What's missing from this is the perspective of the population. How are health systems working for the user? Next slide, please. So why do user perspectives matter? Why should we go to the population to find out what they think about the health system? We, after all, many of us are health system experts. Let me give you a few reasons. So one thing is, we know that people can guide healthcare improvement and therefore health outcomes. Why would someone come to clinic if they don't think that the doctor is going to A, be there, or B, listen to them in the visit and be able to solve their problem? Why would they adhere to treatment if they don't trust the care that they're getting? So if we understand what people want and are getting and not getting from the health system, it can help us actually improve health outcomes. The second point I'll make is that populations pay for the health system. In a publicly funded health system, we need the population to be willing to pay into that system. And this is particularly critical for countries moving towards UHC or universal health coverage. If we're going to make a big reform in the health system and expect people to pay into that system, they need to be seeing some return on investment from the health system. They need to value it. Finally, as we've already heard today from Marian and from Amy, all countries aspire to people-centered health systems. We see this lofty rhetoric in policy documents all over the world from pretty much every organization. But we're hard-pressed to say that we truly have a people-centered health system if we don't know what people think about that system, and we aren't proactively getting their feedback. Next slide, please. So at Quest, we set out to fill what we think is this blind spot in health system performance assessment, which is where the People's Voice Survey comes in. So the People's Voice Survey, or you'll hear me call it the PVS, is a new survey, a new questionnaire that's designed as a rapid assessment of health system performance from the perspective of the population. It can be used in any country. We, as you will see, have used it in high, middle, and low-income countries, of course, with some very thoughtful local adaptation to the health system context in each country. It has about 75 questions and measures the core domains you see on the left side of the slide. Things like demographics and health and patient activation. The second section is utilization of care. So we are able to map how users path through the health system. So for example, how many visits they have, and are they in the public or the private health system? The third section zooms in on care experience for users of care in particular. We ask about care competence, system competence, and user experience for those users. And finally, confidence in the health system, a really critical and novel part of the instrument. We ask about how confident people are in the public health system, the private health system, how confident they are in the quality of services in specific service lines, like care for pregnant women or care for children, for example. Why do we need a tool like this? Well, no truly global tools exist to measure people's versus users' views. So let me pause here for a second. The People's Voice Survey is not a set of exit interviews. It's different than that. It's a population-based, population representative survey of all adults age 18 and older. So we ask people, even if they haven't used care recently, what they think about the health system. The survey is critical because it provides data that we're not getting from other sources. We ask things for which people are the best source, the gold standard of information. And finally, and perhaps most critically, the People's Voice Survey is designed to be a light, real-time instrument that can provide feedback to governments, to ministries of health in a rather real-time way so that information isn't out of date before they can act on it. So it's a much lighter, quicker, and lower cost survey than many of the big, say, household surveys you might be familiar with. Next slide, please. There's a couple aims of the survey that I want to cover. So primarily, we see the People's Voice Survey as a tool for accountability. It's a way to see if from the population perspective, the health system is meeting its own stated goals. Second, the PVS can help inform improvement. We can learn from the survey what's working for people, what's not working for people, what are the pain points in the health system, and integrate those into the health system planning process to improve service delivery. Finally, it can be used as a tool for evaluation. So you can imagine, you can have a People's Voice survey, you can intervene on the health system, make a reform, and then do the survey again as a way to longitudinally track population perspective. And of course, it allows comparison across countries and regions. Next slide. The survey was designed primarily as a telephone survey with a live interviewer. So we have a trained person who's calling people up using random digit dial in most countries and asking them these questions from the survey. In a few countries, we also used online probability platforms, probability panels rather, to survey respondents. As I said, it's a nationally representative survey in every country except Argentina, where it's only the province of Mendoza. And our sample in most countries was 1,000 to 2,000 adults per country. To date, we have completed data collection in 18 countries. You see those on the slide here. Not all of them will be represented in the findings because some of them are hot off the presses. And the countries in blue, Ecuador, Somaliland, and Nepal, are places where we're in the planning stages now for a People's Voice survey. And so the data that I'm about to present to you comes from roughly the middle of 2022 to the middle of 2023. And you'll hear in my upcoming remarks why this is an important consideration when we think about interpreting this data. But this is just a bit on implementation to date. Next slide, please. So as Amy mentioned, we published in December of 2023 a 6-paper series in the Lancet Global Health, highlighting some analyses focused on prominent health system initiatives around primary care, around health insurance and universal health coverage, vaccination, et cetera. I don't have time today to go through each paper, so instead I organized my remarks around some insights, some key policy relevant insights on health system performance that we can glean from the People's Voice survey. So I'm going to start really large with an assessment of the health system overall in terms of confidence. How confident are people in the health system? I'll then zoom in a little bit to primary care. Where do people seek primary care? And what are they getting from their primary care providers? And finally, we'll zoom in to the point of care, specifically ratings from users and the quality of care they're getting from their own local clinic, for example. Next slide, please. So on confidence, there's a couple ways that we measure confidence in the PVS. There's 2 primary components. The first is health security. So we ask people, how confident are you that you would, 1, receive good quality care if you were to get very sick tomorrow, and 2, be able to afford that care. So this isn't global health security in the way you might think of it. This is your personal health security. So two things, that you could get care and that you could afford that care. The other component of confidence is endorsement. And we measure that in two ways. First, on the left side of the slide, we measure this as your rating of how the system is currently working as it's structured today. Is it working well? Does it need major changes, or does it need to be completely rebuilt? And on the right side of the slide, in the past 2 years, excuse me, is the country's health system getting better, staying the same, or getting worse? So this is a measure of the direction of travel of the health system, the trajectory. Next slide, please. So starting with this measure of health security, you can think of this as a universal health coverage measure, whether people can both get and afford care. So the upshot of this slide is that across countries on average, half of respondents in the 15 countries included in this analysis felt they could both get and afford good care if they got very sick tomorrow. So that's the green bar that you see on the left-hand side of the slide in the bar chart. Now, what you'll notice is in every country, affordability was rated worse than your ability to find good care. So what do we take from that? What this suggests is that people know good quality care exists somewhere in the country for some segment of the population. They could access it potentially, but they aren't confident that they could afford that care. Now, of course, these ratings are deeply influenced by local context and expectations among the population. You might notice that Greece and Peru are some of the lowest performers in terms of confidence that they could get and afford good quality care if they needed it. So if you think about what's been going on in these countries in recent years, austerity measures in Greece, for example, and political turmoil in Peru likely influence these measures significantly. Next slide, please. Now, if we look at our endorsement measures, if you look on the right-hand side of the slide in the darker purple, this is the proportion of people who approve of the current system and feel it's working as it is, which you can see is fairly universally low across countries. The left bar chart, this is the direction of travel, the trajectory of health system performance. Is it getting better, staying the same, or getting worse? Now, I'm going to call out European countries in our sample here. You'll notice that for both of these measures, they're quite low, even for health systems that are internationally lauded, like that of the UK. You might also notice for the direction of travel that countries like Ethiopia, Kenya, Laos, and India, they may not be approving of the current system more than other countries, but they are approving of the direction of travel. So one interpretation of this is that if you're starting from a lower baseline, highly visible investments in the health system are felt very keenly, very acutely by the population. So for example, in Kenya, our colleagues in Kenya have explained to us the building of health facilities throughout the country, and also the high visibility of health system leaders during the COVID-19 pandemic. So the direction of travel, then you feel the marginal incremental improvements in the health system much more acutely than somewhere like the UK, where if you're perceiving a junior doctor strike in the NHS, but in general, you feel very positive about the NHS, you only perceive something being taken away or a reduction in competence of the health system. And of course, I should note, these data were all collected from 2022 to 2023. So certainly these reflect management of the COVID-19 pandemic and are very closely related to strength of the pandemic in each country. Next slide, please. Let's pivot to primary care. Next slide. So where are people getting primary care? We measured this in terms of usual source of care. This is not the same as primary care, but it is an important component of primary care. You can think of it as having a medical home in the health system, or a first port of call when you get sick or have a need in the health system. Across our sample, about 75% of respondents have a usual source of care, so 25% do not. You can see there's a lot of heterogeneity in the bar graph of the proportion in each country that has a usual source of care and the public-private breakdown. Now, partially this is due to the health system structure. So of course, the United States, largely a private system, versus the United Kingdom, largely public. this also could speak to a preference, perhaps a perception that quality is higher in the private system. Now, importantly, across these countries, only 44% of respondents thought their usual source of care was very good or excellent. Next slide, please. This slide shows the breakdown of having a usual source of care by level of the health system, primary or secondary. The upshot here is that 64% of people access their usual source of care at the primary level. So in many countries, people are going to hospitals. And this may be a very rational decision if you know that you'll be seen there and that you think the quality of care there will be better. But the important takeaway here is that 40% of people access their usual source of care in the public sector at the primary level, which is typically the part of the health system that we would expect people to go to as their safety net provider, as the first point of call. Next slide, please. I won't go through this slide in detail, but our regression analyses assessed whether people with the usual source of care were getting more care, were higher utilizers of essential services like blood pressure checks, blood sugar checks, or blood cholesterol. What we found is that yes, having a usual source of care is strongly associated with receipt of these important services, even more so than other demographic or socioeconomic characteristics, like having insurance. So this was a really important finding for us. Next slide, please. I just want to say a few words about the quality of care that people receive. So this section, you can go to the next slide, focuses on users of care and their most recent visit in the last year. So just focus on the bottom row of this table here. This tells you the overall quality, the percent of respondents who thought their last visit was excellent or very good. Okay, so these are people who thought their visit was high quality. On average across the sample, fewer than 50% rated their last visit as high quality. So a lot of heterogeneity across countries. You can see in red, Laos and South Korea performed very poorly. And the UK and the US performed very well. People liked their own doctor. At the bottom of the slide, you see some quality pain points where ratings were particularly low. I want to highlight wait time. Across countries, wait time was the poorest performing measure in people's own care, but also measures of care competence like provider skills and clarity of explanations from the provider. Next slide, please. We also disaggregated quality ratings. Who is getting good quality and who is getting poor quality? This isn't good quality and poor quality. It's an important question. This shows one of those stratifiers, self-rated health on the left and self-rated mental health on the right. And what we find is that quality is worse for the sickest users. The blue dots show those with higher self-rated health and higher self-rated mental health. And the red is those with lower self-rated health. And the x-axis here shows the percentage of people rating their care as high quality. So you can see that those with higher self-rated health universally thought that their care was better. And this is notable because people who are sicker tend to have lower expectations of the health system because of greater familiarity with services. Next slide, please. Finally, we were curious, can you buy better quality in the health system? So we know that health outcomes track with health expenditure, but what about quality? So we plotted ratings of care quality at the last visit by health expenditure per capita. And we see a very similar relationship holds. As health expenditure per capita goes up, as do quality ratings. But investment is clearly no guarantee of quality. I'll just point out South Korea here, spending a lot on their health system, though quality ratings remain very low in the sample. Next slide, please. Just to conclude, what can we do with the People's Voice survey? So as I mentioned earlier, it's designed to be repeated. Imagine the power of having a pulse check at one point as a baseline, intervening on the health system, and then doing the survey again. Particularly in a hopefully post-COVID era, it's critical to see how health systems fared from the perspective of the population. The PVS is a 20-minute phone survey. It cannot answer every question, so we really see it as a complement to other sources of information. We think it should be part of a suite of tools that give us a holistic perspective of health system performance, something that could be integrated into strategic planning processes and part of Ministry of Health reviews. So the PVS continues to expand. The Lancet Global Health Series is just our first set of analyses. We're continuing to work on multi-country and regional and national papers highlighting some of these results and new findings. as well as expand the People's Voice Survey to new countries, shepherded through the Quest network. So let me pause there, and I'm very eager to hear your questions on the methodology, the implementation, the genesis of the survey and development, if you're curious. And I'm very eager to hear from Carmen and Rosemary, their thoughts on how we take this data forward. Thank you very much.
Thanks so much, Todd. Thanks for that succinct and fascinating overview of what is really a rich body of data, and also for highlighting that this is sort of the beginning, right? The starting point of how this data can be used going forward. I hope we'll hear from participants in the call how this complements other health systems measurement work that's being done in their own countries. Indeed, there already are many questions popping up in the chat for you. So audience members, continue to feel free to add those in the chat box. We are collecting them and we'll get to them in the discussion part of the session. So now I'd like to welcome Carmen and Rosemary to the discussion. Again, everyone, please remember to ensure your interpretation channel is selected, as Carmen will share her reflections on the series in Spanish. So first I'll hand it over to Carmen. We heard a little bit in Todd's overview there, and certainly we see it in the papers, that the People's Voice survey includes some particularly interesting findings about confidence in and quality of health systems in Argentina, but also in Latin America more broadly. We saw that Latin American respondents had some of the lowest reported health security and experienced significant barriers to health service quality in many countries, particularly related to equity. So we're interested to hear, in your own work at Fundación Huésped with vulnerable and marginalized populations, how do you see the challenges around confidence in and quality of the health system impacting the promise of health for all? And I know that your work also looks a bit at the this kind of perceived difference between the effectiveness of the public health system and the private health system, and what that means in terms of access for marginalized populations. So welcome to the floor. We're interested in your remarks and perspectives as a user of health system in Argentina and as an advocate for social participation for health. Thank you.
Thank you very much, Amy. Just 1 second to give everyone the chance to get to the interpretation channel to Spanish. De ahora en más voy a hablar en español porque voy a ser mucho más precisa en mi lengua madre y voy a poder hacer comentarios mucho más útiles y pertinentes. De todas maneras, creo que puedo hacer un adelanto en algo para bajar un poquito las expectativas, porque siento que la cantidad de información que nos ofrece esta investigación es muchísima y es muy difícil comentarla solo en 7 minutos. Y ahí mi agradecimiento a todos por la presentación, y mi agradecimiento a Amy y al equipo del CISEM y al equipo de MSH por facilitar este espacio, porque como una abogada impulsando el derecho a la salud constantemente, estas instancias de traducción más sencilla de estos findings, de esta información que resulta de la investigación, es muy valiosa para poder desarrollar mejor nuestro activismo, para poder reflexionar sobre nuestras prácticas, para poder tener una reflexión crítica sobre cuál es el estado del sistema de salud en Argentina. Pero bueno, sirva la aclaración de que mi background de formación es derechos humanos y no específicamente salud, así que hay muchas cosas en donde quizás traiga más preguntas que comentarios. Creo que esta investigación es clave y es muy necesaria, y hay que leerla en el contexto político en el que nos encontramos, particularmente en Argentina, pero en muchos países, y en una tendencia global a discutir y volver a reflexionar sobre cuáles deben ser las inversiones de los estados para garantizar derecho a la salud, para garantizar derechos en general, y cuál es el rol del Estado en esa garantía, particularmente al tiempo en que se desarrollaba la encuesta en Argentina, más allá de que se haya hecho solo en la provincia de Mendoza, pero creo que en muchos países hay procesos similares, lo que venimos discutiendo como nuevas derechas o distintas o nuevas posiciones. Me parece que es interesante pensar cómo en el espacio político discutimos cuál es el rol del Estado como inversor, cuál es el rol de las políticas de austeridad, ahí hacía algunos comentarios sobre el impacto de las políticas de austeridad en la confianza y la calidad de los servicios de salud, pero en el debate público vienen tomando más posición y más alcance algunas posiciones, algunos comentarios que nos hablan sobre la importancia de dejar de invertir tanto en ciertas políticas públicas. Y esos comentarios son muchísimo más complejos, o esas posiciones políticas son muchísimo más complejas que estar a favor o en contra. Entonces, este tipo de investigaciones nos ayudan a reflexionar mucho más profundamente sobre algo que aparece en una de las investigaciones y que a mí me genera muchas preguntas, que es las expectativas. En el paper sobre confianza, cuando hablamos de confianza, y cuando se analiza en el paper la confianza de las poblaciones, y ahí pensemos, ¿no? Estamos hablando de usuarios y no usuarios de los sistemas de salud, y ahí yo creo que hay algo súper interesante que Todd remarcó en su presentación inicial. Te voy a pedir, Amy, ya me doy cuenta que no voy a cumplir con el tiempo, entonces yo te voy a pedir, Amy, que abras la cámara cuando esté llegando a 5 minutos, así redondeo, pero porque me genera tantas reflexiones que es difícil cumplirlo. Pero, ¿cuáles son las reflexiones de los no usuarios sobre los sistemas de salud? Ahí me generan muchas preguntas y es algo que me parece que es importante que pensemos, y quienes venimos de promover el derecho a la salud sexual y reproductiva o no reproductiva, quienes venimos de trabajar en las agendas de VIH e ITS, tenemos mucho para aportar y para dialogar con esos resultados. Sabemos que existen un grupo de poblaciones clave que están más expuestas a contraer ITS y que tienen más barreras para acceder al sistema de salud. Cuando leo los comentarios de confianza de no usuarios, pienso en las barreras que en Argentina tenemos para que las personas accedan a medidas preventivas en materia de VIH como la PrEP o la profilaxis post-exposición, que a pesar de estar garantizada hace años, es una práctica que la gente no busca y que cuando la busca encuentra barreras para acceder en todos los subsistemas de salud. Y ahí tengo un montón de preguntas sobre cuánta información nos pueden ofrecer estas investigaciones sobre estas poblaciones específicamente, y unas cuantas preguntas también sobre cómo incorporar la perspectiva de género en estos datos. Se ve claramente algo que desde los feminismos veníamos marcando sobre el acceso a servicios primarios de diagnóstico preventivo en varones adultos y cómo la percepción de las masculinidades, que es también un tema que nos preocupa a los feminismos, ¿no? Cómo las masculinidades se perciben y autoexigen distintas niveles de exigencia en materia de acceso a derechos y cómo no acceden a estrategias preventivas de salud, teniendo luego diagnósticos tardíos que son muchísimo más costosos para los sistemas y muchísimo más gravosos para las familias, para las comunidades. Y ahí también me pregunto cuál es el uso de las comunidades de personas trans y cómo impacta, que me parece muy interesante profundizar. Me encantó leer que esta investigación será la primera de muchas en materia de repetición y la posibilidad de poder evaluar cómo van cambiando estas percepciones a lo largo del tiempo, pero me encantaría saber qué le pasa a las personas trans con el acceso a servicios de salud y qué les pasa en distintos países en donde tenemos o no tenemos leyes de identidad de género, en donde hay políticas para adecuar el tratamiento y la respuesta del sistema de salud a sus necesidades específicas o en donde no las hay. Voy a volver a mis notas para no quedarme sin decirles muchas de las preguntas que nos quedamos, muchas de las preguntas que sentimos que necesitamos hacernos en muchísimo más detalle. Nosotros en Argentina, y veo en los papers que en muchos otros países tenemos un sistema muy fragmentado en donde público y privado no son las únicas categorías, y el sistema de seguridad social, que durante muchos años ha sido para Huésped en nuestro activismo uno de los sistemas que más nos desafía, porque más barreras encuentran las personas para acceder a las prestaciones, se muestra como un subsistema en donde se enfrentan muchísimas barreras, tanto en materia de confianza como en materia de calidad, y creo que quiero retomar para cerrar, porque seguramente estoy muy complicada con el tiempo, pero quiero retomar uno de los hallazgos de uno de los papers en donde nos habla de la necesidad de trabajar con los gobiernos, de trabajar con los sistemas de salud en comunicación más efectiva para que las prestaciones que están disponibles sean accesibles para los no usuarios. Y ahí pensar, ¿no?, en esos no usuarios en función de las poblaciones específicas, pensar en las poblaciones de personas privadas de libertad, pensar en las poblaciones de la comunidad LGBTIQ+, cómo podemos trabajar sobre identidad y también sobre elecciones sexuales en esas prácticas, cómo trabajamos discriminación cuando no sabemos cuáles son las expectativas. Para poder identificar que sufrimos discriminación necesitamos tener una expectativa de respeto y esto me parece que es muy clave. Creo que tenemos un montón de información, un montón de resultados y hallazgos que son maravillosos. Me quedo con muchas ganas de charlar más en profundidad con el equipo que trabajó en Argentina, con todo, con los equipos que analizan y escuchar la mirada de Rosemary desde otra latitud. Pero bueno, muchísimas gracias por la oportunidad de empezar esta conversación que espero que sea la primera de muchas.
Thanks, Carmen. Thank you. And you've raised a couple of points that I think we can discuss with Todd. There are places in the papers that look at the gendered differences amongst respondents' findings, particularly also in relation to key affected populations. And I'm glad that you also emphasized the user and non-user. I think it was important that Todd highlighted that this is not only a survey targeting end users of the health system. And so maybe in the discussion part, we can dive a little more deeply into some of those findings that are throughout the series. Also appreciate your particular reflections on the way that, of course, political realities shape both the funding and support and accessibility of the health system, discrimination, and confidence. I think we see that coming up in the papers. Certainly we can talk with Todd also about how that charge to sort of continue to do the survey going forward may reflect and highlight some of the changes that are happening since political systems are, of course, directly affecting the health system and the rights of people to access healthcare in their countries. Now I'd like to turn it over to Rosemary. Rosemary, Todd did already highlight a little bit some of the particularly interesting findings from Kenya, talking about the findings of increased confidence in the health system, some particular reflections on the National Health Insurance Fund and the way Kenya has been moving towards universal health coverage. As Todd discussed, the papers suggest that high confidence in the health system may be in part because of, highly visible investments in the health system. And I wonder if your experience living in Kenya, being a user of the health system and as an advocate fighting for access to essential health services for everyone, why do you think this confidence in the health system has increased in recent years? Has citizen engagement and involvement been a part of that? We welcome your overall reflections and perceptions on the finding of the series. Thank you.
Thank you so much, Amy. Good afternoon, good morning, good evening, colleagues. So it's a pleasure to share reflections based on this conversation today, and specifically to respond to your questions, Amy. And before I do that, I would really want to applaud this idea, this initiative of using the people's voice, the reflections and experiences of users as a measure of health systems, and really bringing the voice of the user, the people's voice. It's such a terrific idea and a direction in the right side in terms of accelerating advancement towards people-centered systems for health or health systems. To your question, I have about 4 reflections. The first one is to, I guess, to remind us, to reiterate that health is political. And given that health is political, it means that if there is high political support for an agenda, like the UHC agenda in Kenya, which is what I want to zero into in responding to some of the reasons why we might see this confidence going up, is that with Kenya's previous administration, because I see this survey was conducted, we are talking about mid-2022 to end of 2023. So just looking at the last decade, a couple of things happened in Kenya, which I think have contributed to this kind of progress. But then at the end of my reflections, I also want to give a few caveats and reservations that I have around this as well. So health is political. And so the previous administration, the head of state actually made UHC a national priority. And when His Excellency President Uhuru Kenyatta identified UHC as one of his legacy projects in Kenya as he was preparing to exit the space, it did a couple of things and a couple of shifts within that space. So the issue of highly visible investments, you could actually look at how that could be associated with the rising confidence that was identified through the people's voice, because indeed we saw increased investments around UHC specifically, which is one of the caveats we'll give at the end, is that we saw increased number of facilities. So I remember him saying one time that during his tenure, and he did 2 terms, of 5 years each, the number of medical facilities increased by 34%. It was around 1,000, about 1,200 in numbers. And so I think from an optics point of view, just having users and citizens see something is happening, see there is a prioritization at this level, even if it's facility, increments, is infrastructure, etc., there's something it does to the optics. So from I think in terms of perception, there's something there around making health and UHC a high political agenda, which translates to strengthening health systems. And in this case, the example I've given is, I think, setting up infrastructure. At the back of that, I would also want to add that over the last 10 years, again, Kenya has been, I would say, operating, the health sector operating through the devolution, arrangement of governance here in the country. And so with devolution, where things transitioned, from a national government to 47 county governments, which actually brought people closer home in terms of setting up facilities at county level. And therefore, I would say strengthening from an access point of view, where counties, are setting up facilities, clinics, and so on and so forth. The county leadership, I would say, is something else, to speak about in terms of crediting that kind of confidence. And that is also a political kind of process in terms of how county governments also prioritized health. So I think that is also very important to highlight. I also want to highlight that during the COVID-19 pandemic, we saw strong leadership from Africa. This is not to say that there weren't struggles. This is not to say that the response was perfect. But as the world was struggling with the pandemic, as countries were struggling, we saw how African leadership, given the fact that our health systems have been affected in a sort of chronic ways by other epidemics, given the investments are not to the level that is desired, the way the region, many countries in Africa responded to that kind of leadership brought some kind of visibility. And even though initially there were issues of trust, I think the more our government continues to communicate and to engage citizens in terms of risk mitigation, and like we are in this together, I think it helps to develop some form of trust, because we were in this together, it was a crisis. And I think that did something around that. I also wanted to mention that possibly there is also the effect that comes from the impact of partnerships. I want to mention, like in many African countries, when we talk about health systems, we also talk about the partnerships that invest towards those health systems. So the exchequer resources is little, but that plus the global health initiatives like the Global Fund, like Gavi, the Global Financing Facility, is also something to mention in terms of their catalytic nature. And I think in view of this survey, it's, I think, important to point to the fact that during COVID-19, those global health partnerships, jumped into the support and response and really rapidly supported countries with financing, community health workers, training vaccinators, etc., etc. So those are some of the things that came to my mind. And in terms of then the National Health Insurance Fund, like the social insurance, one of the things that, as I was reading and trying to see what is the coverage in Kenya, one of the numbers that came up for me was that by the end of 2021, about 10.5 million Kenyans had subscribed to the National Health Insurance Fund. Even though right now, as we speak, there is a transition, that has been taking place from the National Health Insurance Fund to the Social Health Insurance Fund. So we are reorganizing that space as a country. But the point is that there is a provision, for social insurance. And I think we are going to grow in that direction. It's not perfect. It's not free of challenges. But I think that direction of like who pays for care, and in this case, the national insurance is one of the structures that I think the country is going to improve on. So having said that, in terms of some of the things that are working, and remembering that, it's not just in Kenya, actually, it's important to mention that even though our president, couple of years back, our former president, couple of years back, put UHC and therefore health systems as a priority, globally, we also saw quite a bit of movement around health systems. We saw in 2017, there was the political forum on UHC. Again, later on, I think 2019, we had the high-level meeting on UHC, and again 2023. So that political momentum counts, when it comes to the country level. But I think the caveats I wanted to put, because I think that answers the question that points us to the shift. Why more confidence? Why can we? So I think it's those things. But I think back to the presentation that Todd presented, I think it's important to note that, yes, you have, highly visible investments, the health facilities, the medical centers, and so on and so forth. But I think what we are agreeing, even from the study, is that it doesn't translate into quality health services. And so it is true, and it validates the point also indicated by the study that there was more confidence in the private facilities than in the national public facilities. And that's just because of the nature and characteristic of how care is provided in private facilities, which takes us back to the issue of trust. Like how many people, actually seek out care where their first point of care is like a national public facility. So I wanted to put that caveat, and also to say that, even with all that, we are still seeing increasing out-of-pocket expenditure, in Kenya right now standing at 26% of the national health budget expenditure. And so, like, really great to get the feedback, great to see the confidence going up, and it's a great conversation starter to say, how can countries like Kenya, where this study was conducted, actually continue to move with that trajectory in terms of strengthening confidence, but then now bring along the quality and bring along the coverage in terms of leaving no one behind, connecting back to the points earlier around making sure that even as we get the feedback in terms of the confidence, but what is the experience, especially like Carmen mentioned, of people who are most likely to be missed by health systems, either because they are criminalized, either because they are disadvantaged, they are in the rural areas, and so on and so forth. All those bases for being left out once they are considered. To what extent can we still talk about confidence? I thank you very much. Back to you, Amy.
Thanks, Rosemary. Fantastic points and some specific, really good examples from Kenya, which I think a country people are looking at for a model of universal health coverage. Some important points about communication and engaging with citizens, and thinking about the connection between what is paid out of pocket and the quality of care. There are so many interesting questions coming into the chat, and I want to give Todd a chance to come back in as we get started on your questions. There are a few questions about methodology. Rosemary and Carmen both highlighted, as you already mentioned, the non-users of the system are those who are often left behind in measurement. I wonder if you want to just speak briefly, Todd, a little bit about the methodology, the other PLOS resources, and how you were reaching the people to participate in this survey. Thanks.
Absolutely. And thank you, Carmen and Rosemary, for those excellent comments. You're really speaking our language, I have to say. So many of the things you said really resonated with me, and discussions we've been having throughout the Quest network about what this data means and how we take it forward. If I may just pick up on a few things, Amy, nod to me if that's okay before I move on to
Yes, of course, please do.
Okay, great. So first of all, I want to be very transparent about what the People's Voice survey can tell us and what it can't tell us. As I said, it's a short survey, and we ask people that things are, we ask people things for which they're the gold standard, but we cannot ask everything. So what I think the People's Voice survey does exceptionally well is give us a signal of where the health system pain points and bottlenecks are. It signals those things, but it does not provide solutions. It does not provide policy solutions. And this is where conversations with decision makers, policymakers, population advocates like Carmen and Rosemary are so critical. This survey was not designed to generate data that's going to sit on a shelf. We are going through the process now of sensitizing governments to this information. We have a number of standard outputs, policy briefs that are basically, there's static dashboards with key findings from the survey in each country, as well as longer technical reports with survey output. And our Quest colleagues in each country are having conversations with policymakers and decision makers about those findings and how to interpret them. And in many cases, the Ministry of Health is already involved from day one in actually implementing the survey. So we bring them along for the ride from the very beginning. But in particular, I fully agree, Rosemary, about the political nature of health systems. One thing we found in the confidence paper is that in terms of the universal health coverage measure of confidence, that you can both get and afford good quality care when you need it, we found that people who felt like the government took their feedback into account were much more likely to have confidence that they could both get and afford care. And so your confidence in the health system is deeply tied to your perception of trust in the government, not only in health systems, but in all social services. So in settings where there's widespread mistrust, or there's been corruption, or there's been political upheaval, this affects the health system. One of our colleagues in Peru reminds us always about the very short tenure of ministers of health in Peru. The average tenure of a minister of health in Peru in the last few years has been in the few months. So it's hard to divorce perceptions of the health system from the political reality. And I also wanted to pick up on something Carmen was speaking about, and actually, Rosemary, you too mentioned this, about the importance of understanding the perceptions, confidence and trust in particular, but also quality of subgroups within the population. Now, in a 2,000 person sample, while we can disaggregate, and I think this was one of the methodology questions that came up, we can disaggregate for some indicators, urban, rural, male, female, things like that. But we can't say much because samples get quite small at, say, a subnational level. So it makes it difficult. But in wave 2 of the survey, what we're really interested in is expanding the survey to a larger sample and oversampling some of these populations that have been overlooked from health system measurement. Their perceptions are almost never taken into account, even in small surveys. So these would be groups like, say, migrants in Europe. We could oversample migrants to understand their perceptions and experiences in the health system, what quality they think they're getting. LGBTQ populations, elderly populations that might be left out of this kind of measurement. And so I think in future waves, this is something we're thinking really critically about. And of course, it comes down to sample and budget and all sorts of practical considerations. But from a theoretical standpoint, we really think this is important. I know there were a number of methodology questions.
Yeah, Todd, I'm going to share the PLOS article if you want to refer to that. People are really interested in the countries, why the countries were selected, how this was done. Yeah, great. So as Amy mentioned, we published a concept paper in PLOS Medicine last year that describes some of the genesis, the development, the validation, and implementation of the survey with some of the nuts and bolts of how we did this. In terms of country selection, this is a really great question. The core countries that are part of the Quest network, we all co-agree. We agree together, the network of principal investigators from each country, on what projects we'll do. So they all were the first group to take up the People's Voice survey, and we're all involved in the development and design of it. Other countries really came to us. There is an immense appetite for this sort of information in pretty much every country in the world. So sometimes it's an academic organization, sometimes it was the Ministry of Health saying, hey, we see the value in a tool like this. So really it's a constellation of people who really saw the value in this kind of information and reached out to us to produce the survey with them. Other methods, questions, Amy, that came up multiple times that I can address? I think that's helpful, Todd. A lot of interest in having their own countries included and thinking about how this data can be available for use in their own advocacy. I want to raise another question, Todd, particularly from our Sphere social participation partners. Of course, you've talked a lot about how the study sheds light on the association between social participation, which is really involving the voices of communities and users or non-users of systems and in shaping the health system, but it's not clear the extent to which people's opinions are actually taken into consideration, right? If they're shared with those governments. In other words, the path by which social participation potentially does promote actual health system strengthening. Is there any plan to assess this or do that kind of measurement in future studies? Yeah, this is a great question. To be fully transparent, this series came out in December. So we ourselves are figuring out, what does this look like to feed this information back to governments? Will they take it up and how will they do that? This is why conversations with folks like Carmen and Rosemary are so powerful, because they have insight on how you take data to action far more than we do from a survey that really can just signal areas where populations are desperate for attention and focus. So as I said, a lot of these sensitization conversations are happening now with ministries. It's been very fascinating to see which indicators resonate with the people who can make decisions around these things. I can shed some light on conversations in Ethiopia where the unmet need for care, so this is something else we ask in the survey, was there a time in the last year where you felt that you needed care but you didn't get it? This is something highlighted in, I think, the second paper of the series, if you're curious to see the results from each country. This was of huge interest in Ethiopia among the Ministry of Health. And so this has been a learning process for us as well. What we do know is that there is really good evidence actually showing that the experiences and perceptions of people and improving user experience can improve health outcomes. So we know that pipeline, it exists, it is possible. Being able to sort of formalize, standardize, and make that process routine, especially at a national level, I don't think that's something that we know a lot about how to do well. This work grew out of the 2018 Lancet Global Health Commission on High Quality Health Systems.
one of the universal recommendations from that commission was generating demand for quality among the population. And this is an area really ripe for further research. If any of you out there are interested in how to generate demand, please go forth with it. This is something that I'm very interested in, and certainly as a natural outgrowth of the People's Voice Survey. We don't have great examples at scale of how to encourage the population to demand quality, even though we know it's really critical. So those are just some thoughts.
Thanks, Todd. I'm going to pick up on that quality point. There have been a couple of questions about perceptions of quality of care, right? That you're surveying people about. Those may depend on expectations about what actually constitutes quality of care. And also some questions related to kind of self-reported perception surveys, right? Being highly contextual to variables that make the cross-country comparisons difficult. Again, what are the citizens' expectations? Have you collected or will you be collecting any data about that?
This is an excellent question. We could probably spend the next 2 hours talking about this alone. What I will say is that in population-based surveys, responses come with all of these layers, all of this residue of expectations, of experiences, of social desirability biases and courtesy biases. And on some level, it's very hard to divorce people's responses from these lived experiences and expectations. We interpret all of this data. If you go to the discussion papers of the discussion sections of all the papers, you'll see that we bring this up in almost every context. We have to basically assume what expectations might be in different countries from previous studies, and we interpret very cautiously with that in mind. So fully recognize that expectations is a critical part of interpreting this data. What I will also say, though, is regardless of the multi-country difficulties, multi-country comparisons and how expectations might muddy those, within a single country, this is the perception people are walking around with of the health system. This is what they have in their head as they're thinking about the health system. And it's really important because even if it's informed by expectations, it does give us a signal of whether they will A, use the health system, and B, buy insurance. They're two critical things we really care about. So the last thing I'll say is that we do actually try to measure this in the People's Voice Survey. So a bit of a teaser. We ask 2 vignettes, which are short stories about care. And you can do some tricky analytics to use those to measure people's actual expectations and then adjust their ratings to basically adjust the expectations out of their ratings. So that's an analysis that I'm working on right now, actually. And I think in the next few months, we will be able to make those available and actually measure, empirically show how much expectations are influencing some of these ratings.
That's fantastic. Rosemary and Carmen, I also want to give you an opportunity to come in. You can be thinking about it. You don't have to do that right now, but with other questions that you may have for Todd or questions that you want to help to respond to. We're going through some of the specifics of the survey, but there have been some questions also building on how will this, how will this data be shared? Todd, there's another question about, this is a really important, the population-centered nature of this survey. And you were just talking about perceptions. As others, perceptions impact our own impressions. There's a question about if someone is tempted to use this as an exit survey, what are the opportunities or pitfalls of that?
Yeah, this is a great question. So, exit surveys are powerful in their own way. So one key advantage of those is that the care people got is incredibly salient. They're walking out of the health facility just then. I mean, it's fresh on mind. We in a survey like this are subject to some recall bias, for example. So there are some advantages. I think the disadvantage is that you're missing the non-users of the system. And I mean, this is critical to us because these people may have been past users. So we want to understand why are they not users today? And also they may be future users. And even if they're not users now or in the immediate future, we may still need them to pay into the system and support the direction of travel of the system if we want it to function. So while I think exit interviews can be a very powerful tool, I think a population-based nationally representative survey is also necessary. And to be totally transparent, I see them as complementary. The PVS cannot answer everything. It one survey. And so I think the more information we have, of course, with thoughtful measurement, really intentional measurement, I think the better.
Thanks, Todd. Rosemary, one of my MSH colleagues in Kenya has shared a question for you. I wondered if you might be willing to engage with this. The government of Kenya recently conducted the National Health Facility, sorry, it's sliding away from me here, the National Health Facility Census, which was a comprehensive assessment of the Kenya health facilities to gather data aimed at informing policy formulation, planning, and programming in the health sector. Do you think the Government of Kenya Health Facilities Assessment report would reaffirm these People's Voice survey findings, if you're familiar with it?
Yeah, so actually, I haven't seen the report, I must say, and I wonder whether Wawera has seen the outcome and whether there is alignment. My thinking is that it might in some indicators, it might not in others, based on who the respondents were and how it was conducted. I mean, the People's Voice survey is very specific in terms of, it's like a social kind of survey reaching out to users. And I think in the government facility census, I think that's something to look into in terms of, who was reached, the sample, and so on and so forth. But I think it's a very good tool. It's an entry point in terms of, I think, advancing the conversation of what that report shows. And I think that's where citizen engagement might be mostly useful. I like social participation, making sure that the outcomes of these assessments becomes a starting point for engagement, for policy formulation, which is the intended use of this. But I think the question is whether within that, is there a voice from users? Like, to what extent was there citizen engagement? I think that's where I think the dichotomy might be in terms of the results, like the perspective, like, we are responding to this from whose perspective? People's perspective, providers' perspective, everybody included, and so on and so forth. So very happy to perhaps, touch base with Wawera, look at that and see how it can inform our conversations here in Kenya.
Thanks. And Carmen, I wonder if you want to speak. There's been some discussion here and a bunch of questions about how governments are being sensitized. Todd has talked about that, some of the direct engagement with ministries of health, how awareness is being raised, and sort of in your own work, including the social participation work and the work with communities. What do you see the potential being for taking this data, and leveraging it for your work with the government?
I see such a huge potential on this project, on the data we have, on the potential data we can have on the next year. So it's really enlightening to hear Todd comment on the possible next waves and on the dialogues with national authorities. We have to have some concerns as civil society on how some particular data could be used to promote changes without thinking on the rights of people, because we need to hear people's voices, but as Todd was saying, this is in complementarity with other studies, other opinions, other dialogues. So I think it's key to have spaces where civil society, researchers, activists talk with the researchers, with the people that are participating on these dialogues, and talk with each other so we can dig deeper on what are the expectations. I think we need to work harder on the expectations for everyone participating in the call. Argentina has this slightly different situation between quality and trust. While trust gives us a really poor number, quality seems to give us like a better sensation. So it's really difficult to work on those numbers alone, and we need to work with them in dialogue with each other and with other sources of information. So I think this is gonna be a really helpful and enlightening conversation. It comes up in a really good timing because we need to have this debate. And so Well, I'm really hopeful. I'm leaving this conversation and I'm leaving the reading part of this process with hope, also with concerns, because it's difficult to open these conversations. Of course, we need to, when we say that the public health service in Argentina that has been long-standing and giving free attention for many people, it has no trust from the community. It's rated as poor quality, and we are debating the possibility of cutting the funding for that. It's a debate we have to take really seriously, and we have to, but this kind of data is going to help us take this debate to the right tables, to deep in the conversation, and not have it just as political will or not.
Yeah, thanks, Carmen. And we're also already leveraging some of this data in the global advocacy around the upcoming World Health Assembly resolution that we're working on together, pushing for those global commitments as well as the specific country commitments. I want to give Todd a moment to talk about next steps for those of you who may be interested in doing a People's Voice survey, and then I'll hand it over to Dan to wrap us up for today's webinar. Todd?
Thanks, Amy. Just briefly, we imagined from day one the People's Voice survey, the tool, and the data being a global public good. We're not in the business of hoarding data. Every country that does a PVS owns its own data and is free to publish on it, share it as they will. So later this year, keep an eye out for that data set being available for use for health system researchers and for a way to engage with the tool also on our website, questnetwork.org. That'll be available later this year. And just to say, the People's Voice survey continues to expand. And so if there are questions about how you can implement your own survey, questions for me about that process, I very much welcome them.
Thanks, Todd. There are lots of questions remaining in the chat, so we're also happy to engage with all of you. The webinar is being recorded. It'll be posted, opportunities to communicate with MSH for that. Carmen had a chance to kind of give her sum up, and Todd too. Rosemary, any final points from you before I hand it over to Dan?
I think mine is just to emphasize on the opportunity that Shraddha has put on the chat around the WHA resolution on social participation. I think it's an important moment, and there are tools from civil society that can help us mobilize that support, because it's in turn helps us at country level to make sure that we advocate, first of all, to ensure that people's voice is included in giving feedback around health systems.
Indeed. Thanks, Rosemary. And I think we've shared the link to the tools that the Civil Society Engagement Mechanism for UHC 2030 has prepared for anyone who wants to get involved in that advocacy. Thank you all for those questions, interventions, ideas, sharing. I'm going to hand it over to Dr. Dan Schwartz, the Vice President of Global Health System Innovation at Management Sciences for Health, for a few closing comments. Thanks, Dan.
Thanks very much, Amy. Thank you, Marion, Todd, Carmen, Rosemary, and to all the conversation in the chat and the questions we received. I have completely lost track of all the notes that I've been taking. Suffice to say, it's been a very rich discussion. But no one came here to hear me talk today. So I'm just going to offer a couple of closing thoughts. And I think I wanted to start by going back to the mother that Marion started this conversation with, which is to say that we should never lose sight of that mother, because ultimately that is the core of this conversation. And that should be the core, the centrality, the totality of our focus in high quality person-centered health system strengthening. And I think that Marion raised an important point, which is that, how does that mother with that sick child, how does she make decisions? And highlighting a couple of points that came out in the discussion. Number one is information asymmetry. She may not actually know much about what a particular clinic or hospital can offer her. And she certainly may not know what the objective clinical quality is, but she does have either trust or, as Rosemary and Carmen highlighted, a lack of trust. And if we can't get past that trust barrier, we'll never get past the access barrier, which will never get us to high quality actual healthcare service delivery. And in that regard, I wanted to amplify Todd's points that ultimately the People's Voice survey is as the papers themselves say, is a start of a conversation, is a single tool in our overall toolbox, is a part of a suite of tools, is a complement It is not the totality of perfect information. It has its own biases, and I want to amplify and appreciate the many comments in the chat about methodological challenges in this regard. And my personal reading of the papers, and Todd and Margaret and Ezekiel and their many colleagues, is that they're approaching this with humility and recognizing that there is no such thing as a perfect data set, but that multiple information sources can help us do better, and that we have to keep the idea of the people's voice at the centrality of our focus and in our planning and our policy, driving these data towards policy. But ultimately, we also have to be humble about their own imperfections. And I also wanted to highlight the fact that, as Todd said right at the end, I think it's a really important point. As someone who has had an academic career myself, very few data sets are truly made public. Very few data sets are owned by the people and democratized to be utilized by other researchers, other policymakers. And the fact that the People's Voice Survey is doing that is a really, really important step forward, both in academia, but also in health policy research. And I think we need to consider that in our own work. How do we make our own work democratized and fully available to everyone, rather than seeing ourselves as competitors, seeing ourselves as colleagues in this larger space, and how we can contribute to our own lesson sharing. Ultimately, you know, I did want to comment. I saw we didn't have time to address in the chat. There were some comments about the divergence between self-reported quality and clinical quality, and I think that that's important. You know, some of the prior work that is done by the Lancet Commission on High Quality Health Systems certainly has highlighted that access is unfortunately no longer the #1 barrier to mortality. It's actually quality. But again, as Rosemary said to us, without that trust, we'll never get past that barrier. So I want to end, and I realize we're running out of time. I want to end with gratitude to everyone for coming today. And I want to end by bringing us back to the woman that Marion started this conversation with. We're all here for her. We're all here for her community, and we're all here for her child in the future. And I hope that we can take these data and we can take these tools and collectively improve them together, because that's our responsibility. Thank you all. I'm excited for the future, and I hope you are too. Cheers.
Thanks, Dan. Fantastic summary. Thanks to all of you for your participation. A quick shout out. Join me again in a virtual round of applause for our presenters today, and for all of you for your engagement. I do want to thank the team behind the scenes, Joanne, Christine, Jenna, Weiswa, Ashling, and others who've worked so hard to make this webinar a possibility. Our thanks to the Quest team. A reminder that the webinar has been recorded. You'll receive a follow-up email with a link to that if you're interested in sharing it. We'll also be talking with Todd and the team about how we may reflect on some of the questions we didn't get to, or the fantastic questions you shared today in a follow-up piece. We hope you'll continue to join us for future conversations at Management Sciences for Health about this work to really build a focus on and strengthen approaches to people-centered health systems. Thanks again to our colleagues from the Sphere Network and others. Thanks to all of you for being here for a fantastic conversation, and great job, Todd, Carmen, and Rosemary answering all of those questions. Enjoy the rest of your day. Thank you.